alaikum wa rahmatullahi wa barakatuh. Today we will speak about the cardiovascular drugs, calcium blockers. What are the calcium channel blockers? Calcium channel blockers were initially introduced for use in the United States in 1981, and extended release formulations were available 10 years later. يعني بالبداية أول ما طلعت الكالسيوم channel blocker ما كان أكو extended release، بعدين سووا extended release formulations. Indications for use of these drugs are angina, hypertension, arrhythmias, subarachnoid hemorrhage, and migraine prophylaxis. What is the chemical structures of calcium channel blockers? They are either phenylalkylamine derivatives, like for example verapamil, or benzothiazepine derivatives like diltiazem, or they are dihydropyridines like nifedipine, phenidipine, nimodipine, nicardipine, amlodipine, lircanidipine. Or they are diaryl aminopropyl ethers like piperidine, and the fifth group, it's the tertraline derivatives like mibifradine. So these are the chemical calcium channel blockers. Now, antagonisms of L-type channels result primarily in effects on the heart and peripheral vascular smooth muscle. They can cause negative chronotropy, decreased heart rate, or negative inotropy, decreased cardiac contractility, or decreased cardiac output and hypotension. So they are calcium channel blockers, so they antagonize the L-type channel and give these effects, which are negative chronotropy, negative inotropy, and decreased cardiac output. And so what are the pharmacokinetics of calcium channel blockers? We have a comparison between the verapamil, diltiazem, nifedipine, and amlodipine. So they are all are absorbed, more than 90% absorbed, and the volume of distribution of amlodipine more than others because of its lipid soluble, so it have a volume distribution very high. And for the protein binding also amlodipine more than others, but all have a high percentage of protein binding, and the half-life of amlodipine more than others. So amlodipine in the body. Calcium channel blockers block calcium channels L-type in heart and blood vessels, prolong depolarization, increase QRS width, block SA and AV node conduction, heart block asystole causes by the blocking of SA and AV nodes cause heart block and asystole. Also they cause vasodilation effect. They are vasodilators and cause cerebral protection. So calcium channel blockers cause prolonged depolarization, block SA and AV nodes, vasodilatation action. Also, calcium channel blockers causes hypotension. Why? Because of peripheral vasodilatation and myocardial depression. Also, calcium channel blockers can cause bradycardia. Why? Because of AV and SA nodes. What is the pathophysiology of calcium channel blockers? Calcium channel blockers have three main sites of action. They are either work on myocardial muscle, or cardiac conduction system, or vascular smooth muscles. L-type voltage sensitive slow calcium channels located in cardiac, smooth, and in myocardial cells, calcium entering via the L-type channels triggers release of stored intracellular calcium affecting excitation, contraction, coupling. So بالمyocardial cell قلنا الكالسيوم entry to the L-type channels راح يساعد على إنه يسوي ريليز للستورد intracellular calcium، فراح يسوي excitation, contraction, coupling، فراح يصير excitation and contraction to the cardiac muscle. فبالcardiac pacemaker cells اللي هي ال SA وال AV nodes calcium entry via the L-type channel allow for intracardiac conduction via the SA and AV nodes. بالvasculature اللي هي يعني بالblood vessels calcium influx هتسوي tonic. Clinical manifestations of calcium channel blocker toxicity احنا اللي يهمنا بالtoxicology والtoxicity. They cause overdose, they cause hypotension, they cause cardiac dysarrhythmia, bradycardia, gastroenteritis, adult respiratory distress syndrome, depressed level of consciousness, hyperglycemia, and what is the strategy for the treatment of calcium channel blocker toxicity? Establish ABC. First of all, we have to establish ABC, which is the what we call it the يعني these are obtained intravenous IVSS provide oxygenation. فاحنا عندنا ال AB اللي قلنا هي أول شيء بالنسبة لل So first of all we establish ABC. A meaning the airway, where B here breathing, with C circulation. So we have to obtain intravenous access, provide oxygenation. So administration of activated charcoal أيضا it's very important. Repeated doses may be used, especially with ingestions of sustained release agent. خاصة إذا المريض ماخذ sustained release agents هاي يعني ما صار لها release بعده. فالactivated charcoal very important in this situation. Whole bowel irritation with polyethylene glycol solution أيضا ممكن إنه الباول irritation تفيد بحالة sustained release agent. والصوديوم bicarbonate والاتروبين. So it's the treatment of calcium. Calcium salt is very important. Calcium chloride 10% in case of verapamil and tiltiazine. Glucagon 5 to 10 milligram or 2 to 10 milligram per hour acts via cyclic AMP to increase cardiac contractility and also may decrease heart block. So glucagon is very important because it acts through the cyclic AMP to increase cardiac contractility and to decrease heart block. So it is very important for the treatment, calcium salt and glucagon. Inamrinone is very important in the treatment of calcium channel blockers because it is an inhibitor of phosphodiesterase 3. Insulin dextrose 0.1 to 1 unit per kg per hour IV with mean doses of 0.5 units per kg per hour. It's very important in this situation. Also, we have to use hemodialysis and hemoperfusion if the drug is have low volume of distribution. Because of these calcium channel blockers all have high volume of distribution, so hemodialysis and hemoperfusion are not effective because of the greater volume of distribution of drugs. If the drug is stay in the blood, so it have low volume of distribution, then hemodialysis and hemoperfusion. So now we speak about the ACE. What are the angiotensin converting enzyme inhibitors? This class of drugs include like elaceprol, captopril, enalapril, fosinopril, lisinopril, ramipril. So these are called angiotensin converting enzyme inhibitors, or we call them ACE inhibitor drugs. These drugs have similar therapeutic indications, all have the same therapeutic indications, all have the same adverse effects and contraindications, but they differ mainly in their potency, route of elimination, duration of action. Also, they differ in being prodrugs or active drugs. So we have an example for the prodrugs, which are the pentopril, ramipril. Now we can speak about the renin angiotensin system. As you know, we have angiotensinogen, which is stored and can be converted to angiotensin 1 by the renin enzyme. And this step can be inhibited by decreased renal perfusion pressure or decreased sodium at macula dense cells or increased sympathetic nerve activity. So, and now we have angiotensin 1 converted to angiotensin 2 by the angiotensin converting enzyme. And angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. So, as we said, if we have when angiotensinogen converted to angiotensin 1, so angiotensin 1 either converted to angiotensin 2 by ACE enzyme, the angiotensin converting enzyme, or converted by endopeptidase to angiotensin 1 to 7. So this causes releases of ADH, antidiuretic hormone, or increase prostaglandins, natriuretic, even nutrition, natriuretic, and increase sodium, and decrease renal vascular release, and there is decrease in blood pressure, brain steam, or even may have effect on ACE inhibitors. So these are the angiotensin 1 when converted by endopeptidase, or it can be converted to angiotensin 2 without angiotensin converting enzyme, for example by kinase in the heart, and then when angiotensin 2 when angiotensin 1 converted to angiotensin 2, so it can be converted to angiotensin 3 by aminopeptidase. Now we have what are the effects of angiotensin 2? Support of the blood pressure. How angiotensin 2 support of blood pressure? By which mechanism? First of all, by vasoconstriction, or by direct renal sodium retention. It can cause sodium renal retention by angiotensin 2, or can be affect aldosterone enzyme secretion, and this also causes water on sodium retention. Or angiotensin 2 can cause thirst، خلي الإنسان يشعر بالعطش. وأيضا angiotensin 2 can stimulate antidiuretic hormone release, and this is also cause water and sodium retention. Also can cause sympathetic facilitation central nervous terminal, high ganglionic, or angiotensin 2 can cause increased cardiac contractility, and this can cause support أيضا blood pressure، وأيضا ممكن أن يسوي cardiac and vascular hypertrophy angiotensin 2. So all known physiologic effects are mediated by the angiotensin 2 type 1 receptor. As you know, angiotensin 2 type 2 receptors, angiotensin receptors type 1. These are mediate the effects. What are the adverse effects of angiotensin converting enzyme inhibitors? They can cause hypotension, renal insufficiency, if bilateral renal artery stenosis, hyperkalemia, special group of patients, sodium restricted on potassium sparing diuretics or COX inhibitors, cyclooxygenase enzyme inhibitors. So they cause hypokalemia. Cough in 20% of patients were angioedema. These are by kinin related to kinin release. With captopril, especially captopril can cause neutropenia, nephrotic syndrome, skin rash, taste disturbances. This is due to SH group because captopril contains SH group in its structure, so it can cause these side effects or effects. These are the chemical structures of some ACE inhibitors like captopril and sectional derivatives of proline. هذا عندنا راح تنطينا كابتوبرول وديزينوبرول والإنالبرول، هاي الستركتشرات مالتهم. شوفوا هنا اس اتش ستركتشر بالكابتوبرول هو السبب بالسايد افكتس اللي قلناها اللي هي نيوتروبينيا and other side effects. What is the pharmacology of ACE inhibitors? ACE inhibitors work by blocking ACE enzyme مثل ما قلنا angiotensin converting enzyme اللي هو located primarily in the pulmonary vascular endothelium. موجود وين؟ عندنا بالpulmonary vascular endothelium and prevents the conversion of angiotensin 1 to angiotensin 2. The angiotensin 2 directly act on blood vessels to cause vasoconstriction. فإذا الانجيوتنسين 2 الانجيوتنسين 1 ما تحول إلى انجيوتنسين 2 إذا ما راح يصير vasoconstriction. Angiotensin 2 also stimulates aldosterone secretion causing salt and water retention. So if angiotensin 2 not produced, so stimulation of aldosterone not happen. That's the mechanism. Angiotensin 2 participates in the breakdown of bradykinase to inactive compounds. ACE inhibitors use results in accumulation of bradykinin, which may also reduce blood pressure. عرفتوا شلون mechanism؟ فإذا أن ACE inhibitors very important drugs that can prevent conversion of angiotensin 1 to angiotensin 2 because angiotensin 2 causes the increase in blood pressure and increase in many kinds, increase in decrease in bradykinin. فعندنا لما نعطي ACE inhibitors راح يصير accumulation of bradykinase and this may reduce pressure. Hemodynamic response to angiotensin converting enzyme inhibitors is mediated by substances that bind to opiate receptors. Angiotensin 2 is thought to be inhibited by endogenous beta endorphins. فإذا أعطينا endogenous beta endorphins can cause decrease in. So this is an indirect mechanism of inhibition of angiotensin 2 by captopril. As you know, there is, as we said, angiotensin 2 enzyme can be inhibited by endogenous beta endorphins لأن هي عشان تشتغل على الأوبيات receptors. In vitro studies demonstrated that captopril can inhibit encephalininase, the enzyme that degrades endorphins. فايش راح تسوي increase endogenous beta endorphin. فلهذا لما نزيد الاندوجينوس بيتا اندورفين هو اللي يسوي inhibition of angiotensin 2. So this is an indirect effect of captopril. So the opiate antagonist naloxone is thought to interfere with beta endorphin inhibition of angiotensin 2. فإذا شخص يعني ماخذ نالوكسون أيضا ممكن إنه لأن هذا opiate antagonist, so it's inhibit endorphins يعني الإفكت مالته عكس الكابتوبرول فراح يسوي inhibition of angiotensin 2 يعني قصدي increase. Angiotensin converting enzyme inhibitors can cause renal damage by reducing glomerular filtration pressure, decreasing renal blood flow due to systemic hypotension, and producing glomerulonephritis. How we treat the overdose of ACE inhibitors? Overdose has been reported with captopril, enalapril, and lisinopril. إذا شافوا إنه أكو overdose بالكابتوبرول, enalapril, or lisinopril. A review of the English literatures report 12 of overdose cases. Another study reviewed cases reported to 5 regional poison control centers in the United States over a 6-month period, and 19 cases of overdose with captopril, where 19 overdose with enalapril and 12 overdose with lisinopril were reported. إذا شفتوا شلون يعني صارت حالات بالعالم of overdose خاصة بالكابتوبرول والإنالوبرول والليزينوبرول لأن هي أكثر drugs تستعمل بالنسبة للinhibitors. What is the treatment measures for the ACE inhibitors overdose? First of all, as we said, the ABC, which is maintain airway and ventilation, while breathing طبعا والcirculation والserum electrolyte monitoring, especially sodium and potassium. Sodium and potassium very important. So activated charcoal or hemodialysis is indicated in this case. Hypotension can be treated by sodium chloride and vasopressors. Hypotension can occur with the first therapeutic dose of an ACE inhibitors, and this effect can be blocked by naloxone administration. من يصير hypotension ننطي naloxone administration. ليش قلنا النالوكسون؟ مثل ما حكينا بالسلايد اللي قبله قلنا إنه بالنسبة للبيتا اندورفينز هي اللي تسبب تقلل الانجيوتنسين 2 فإذا انطينا نالوكسون راح يزيد الانجيوتنسين 2. This arrhythmia can be treated by lidocaine and